for giving me a few minutes to speak. I know you're hearing from very different perspectives on the changes offered up by TSH, and I'd like to offer one more. I hold the role of the Corporate Chief of Medicine for both sites of Scarborough Hospital. And amongst my main job is to ensure the quality and safety of care of medical inpatients in the hospital. And it's with that mindset that I'm going to address you. I wanted to point out a few things about TSH, and more so about medicine at TSH. We are the largest single bed user at TSH. We have 125 medical beds at the general site on 5 wards and 71 beds at the Birchmount site on 2 wards. That doesn't take into account another 50 or so beds under the cardiorespiratory patient care team and another 18 beds under nephrology. In addition to that 265 bed total, there are 14 critical care beds at the Birchmount site and 25 critical care beds at the general site. In addition to as part of 100 full-time staff and another 50 locum staff, we have 10 gastroenterologists, 5 on each site. And internal medicine is essentially responsible for the flow of patients out of the emergency room to the wards to a major extent. We usually accept the MRP status for a significant majority of GI cases, both the gastroenterologist and the internists. Internal medicine co-manages many cases with the assistance and side-by-side work with general surgery. And it is general surgery that I'm really only focusing on today. I will not be speaking about pediatrics and obstetrics. I'm really only interested in the provision of care to medical inpatients, and my major concern is general surgery. But not so much a concern. I wish to offer opportunities at the end, and I hope you'll consider them as you move forward. The cases that I've listed above are for the most part co-managed by medicine and general surgery. Upper GI bleeding, lower GI bleeding, pancreatitis, biliary sepsis, diverticulitis, abdominal pain, not yet diagnosed. These are cases that are almost always admitted to internal medicine beds with the regular and consistent assistance of general surgeons. The patients, and we're talking about the patients today and not the doctors and not the physical plant of the hospital, but the patients do require timely and consistent access to general surgical consultation 24/7 for the disease groups listed, but also for the acute surgical deterioration of medical inpatients. When that happens, they're usually quite ill. We also need, and this one is an important point, we need the availability, the scheduling to permit the availability of consulting general surgeons to be providing serial care. We need one surgeon to provide their opinion on Monday and not a different one on Tuesday. We need the same doctor back in the building to provide ongoing care because patients evolve. And rather than changing the thought process every day, we need to ensure we have ongoing patient support. We also need the ability for general surgery to assess patients in the emergency room so that admissions can be avoided, transfers to the other site prevented, and that default referrals to internal medicine, my biggest concern, do not occur. A well-planned and implemented transfer mechanism for inpatients needing next day surgery needs to be created. We've not been very good or efficient at this thus far. Transferring patients has never been a strong suit of our hospital. We need the ability to provide urgent general surgery on both sites to reduce the time to surgery once the decision for surgery is made. And our patient safety will decrease every time a patient is transferred and every handover of care that occurs. My concerns lay primarily with the siting of general surgery at a single site and canceling 24/7 local access to general surgery. at the alternate site, which is perceived by those in internal medicine to affect the rapid access to surgical care for our patients only on one site and creates an inequity of care. Critical care patients in particular require usual surgical support 24/7, and that means general surgery for acute abdomen and sepsis support. And these unstable patients should not be transferred for most surgeries. Medical patients that require general surgery commonly require level 2 care postoperatively, and bed availability may be an issue at one site if a surgery is only offered there. A couple of suggestions and comments. Internal medicine does support the logical and safe reorganization of patient care within TSH and within the Scarborough cluster. We do demand, however, the provision of safe and uniform comprehensive care for our patients across Scarborough, with timely access to consultation, procedures, and surgery at TSH. We do not have safety concerns with the other surgical services, referring to things like urology and things like orthopedics, so long as we have access to the consultants. It is only with general surgeons that we have general surgical care of our medical inpatients that we have a significant concern. The only concern we have with the siting of services on one site is that the patient not be the one being transferred for consultation. When patients are sick, transfers are dangerous, and that it is actually the physician who comes to the bedside as opposed to the patient going to whichever clinic is most convenient. And that is a major concern that we have.
My name is Denis Lanoue, and I'm the president of the Eatwood community. We are located northeast of the Birchmount campus, Steeles to McNichol, Kennedy to Birchmount. I moved in this community 30 years ago, and proximity to the new Grace Hospital built 2 years later was an important factor in our decision. I retired 8 years ago after 35 years career with Imperial Oil, and I'm a chemical engineer with extensive expertise in work process re-engineering and operations of centers of excellence across the country. For several years, I managed the distribution of petroleum products from refineries to customers across Canada. I now volunteer my time for my community, and I'm very active with TSH as Vice Chair of the Community Advisory Council and also helping TSH Foundation. In 2006, I was the co-chair of the Coalition of Scarborough Community, who took on TSH board and had them replaced by Supervisor Rob Devitt, who brought to TSH new bylaws, new skill-based board, and new management team. Recently, I had the opportunity to use the services at Birchmount campus for myself, perirectal abscess, left knee replacement, including physiotherapy, and I brought also one of my 3 grandsons for a broken leg. We had a very positive experience. The Eatwood community is one of the most active communities in Scarborough. Our mission is to improve the quality of life in the community, and the TSH Birchmount campus is a very important component supporting our community of seniors and hard-working residents with young families. As such, we have discussed challenges facing our hospital at every monthly HRA board meeting over the past year, and I participated personally on a TSH steering group for the maternal newborn children care from September to December of 2012. As President HRA, I attended every public session and provided feedback to TSH on our community position that I would like to share with you in the 3 following documents. First one is dated February the 8th, right after the announcement that we got on February 4th. The Eatwood community had a community meeting on February the 7th to review the proposed changes announced as a result of TSH strategic plan refresh. Reference was made to option 2A and 2B from the A report on the website. Following is a summary of our comments and concern. HRA acknowledged the important cost challenge facing TSH and the quality of the A report, where we take exception only to the consolidation of birthing and pediatric into one campus. We believe that the improved service delivery model and the new leadership should be implemented at both campuses for the following reason. We see birthing and pediatric as core services for women similar to emergency room, similar to ER. 2/3 of the babies delivered in Scarborough are at TSH, which accounts for approximately 5,000 births per year, which exceed by far birth rates at nearby hospitals such as Rouge Valley, Toronto East General, North York, Markham Stouffville, etc. Roughly 50% of the mothers will be affected by the proposed centralization. We believe that proximity to the site is most important for expecting mothers. Our second point was, should the consolidation at one site be forced on the community? We strongly believe that siting should be at the Birchmount because we need geographic coverage for the area north of 401 and Scarborough West, and Scarborough West because the General and Rouge Valley are close by in Scarborough East. The presence of birthing and pediatric will also reinforce the Birchmount ER, which is critical to the surrounding community. Major residential development along Shepherd and Finch and Steeles are being built in Birchmount catchment area. And Birchmount campus is much easier to access today and will be in the future when all complex long-term surgeries will occur. Birchmount is also more expandable than the General. Nobody wants Birchmount campus turned into a Branson, which is associated with North York. I think you are all familiar with that. Although we agreed with the major surgeries being centralized at General Campus, we are concerned about how we will be treated if we show up in the future at Birchmount with an acute condition that may require complex long-term surgery. We also urge TSH to ensure that highly qualified staff will remain at Birchmount. Lastly, we are delighted with the return of some plastic surgery at Birchmount, together with the maintaining of the popular fracture clinic and physiotherapy center. This was our thinking on February the 8th. Now, February the 28th, we had supplemental comments submitted to the administration. Over the past 3 weeks, we had the opportunities to talk to several surgeons, physicians, nurse, staff, patients, and community members. Following our supplemental comments to the that the Eatwood Ratepayers Association would like to add to our initial comments dated February the 8th. We strongly demand that proper infrastructures for emergency surgery, including beds and nursing staff, remain at Birchmount. Patients with acute pain visiting Birchmount ER will expect diagnostic and emergency surgery if required for gallbladder, appendicitis, perirectal abscess, colon blockage, etc. The community wants a one-stop shopping for short-stay emergency surgery. The second point, the operating hours for surgeons at the General should be assigned on an equitable basis. It is our understanding that some surgeons from Birchmount have seen their operating hours cut by as much as 50%, which has tremendous impact on the wait time for their patients. The long-stay Center of Excellence for Surgery should put all surgeons equal for accessing time to the operating rooms at the General. The overall implementation of this significant organization and amalgamation of the two campuses should be implemented using a very disciplined process of project management so that nothing falls in the crack, as evidenced as point number 2, which was the rationalization of the hours above, and more importantly, by other factors importing the safety of patients at both campuses and being transferred in between. TSH board and management should do everything possible to build a vibrant, viable, and sustainable Birchmount campus where residents will be confident that they will receive quality health care typical of a urban community hospital. And finally, my third document came later on the March 18 as a result of my visitation to the physiotherapy clinic and the fracture clinic. I suddenly realized that they were planning to close the fracture clinic completely, and some people were trying to tell them that, hey, this is an error doing that and it will affect the community. But somehow I brought this thing up to the management that through a small PowerPoint presentation, that the clinic serves 1,200 patients per month. And I was asking for the reconsideration to revisit the total closure of that clinic. I said, we have no issue with letting the major surgery go, but we need to treat diabetic feet deformities and wounds, babies with hip out of joints who require special bracing and treatment to prevent hip dislocation, patients requiring casting, special bracing, splints, and 2 minutes? Okay, I've finished. There is on a very nice weekend, like the weekend of the summer, they have about 35 patients referred from ER, and if we go into a storm in the winter, they get about 100 patients referred to that clinic. So we are seeing that the Birchmount Fracture Clinic is a very busy clinic, and we should consider keeping it open for those days to provide excellent care to the Birchmount patients. So that's basically what we provided as input from the community nearby the Birchmount Hospital. Thank you. I would say that the seniors need help, and also the babies. The number of babies that we have, at least that I see on my street in my community, it's incredible. I mean, we have the school had to be expanded. We used to have 9 portable in the school. We just went through a $3 million expansion of the school. We are growing, and also. There are people coming in, a lot of people are coming in. We have an Asian community, it's about 90% from different countries in Asia, including mainly China, in our community. But the people are coming and they are sharing the same house, and there are more people per house, and we see the babies on the street and all of it. And they are also the senior people taking care of the children while the parents are working. So what specifically, the people are using the emergency, they are using, some of them have surgery, some of them, like I had to bring my grandson for a fracture of a leg, and eventually he ended up at downtown at the Children's Hospital, but he had the great diagnostic and a temporary cast installed at Birchmount. Well, you must be aware that there was the Chinese community had some bad experience over there, and through papers, and they had a very negative coverage of this thing. So people are simply referring their friends to another site, and some of them are going in Markham. Where we are located, we attract a lot of people from the Milliken area. Just want to make sure that I have time to give the CAC thing, but there was a problem of leadership. And also the value proposition that they were offering was not standard at the general, and so there was a big problem of the two hospitals under the same leadership were fighting with each other. And I was a witness of this thing for 4 months when I was I was the only member of the community representing on this steering group, and it was. I was feeling really bad, but what I really valued, I mentioned it in my speech, is the fact that they were changing the value proposition. They were expanding the services to the community, and they were putting a new leadership that would bring the thing, and we go outreach to the community, which they were not doing before. And I think that you need to replace some doctors in there, and the people are attracted by their doctors and their availability. So I like the concept of doctors moving from one side to another rather than having the patient. Can I deliver my second? Okay.
Any other questions? Thank you for that. And again, I guess that Mr. Rook couldn't make it. You're representing.
Yeah, that's right. So I apologize, and I'm the vice chair. Paul Rook is the chair of the CAC. So I'm the vice chair of the Community Advisory Council, and our council is made of 10 members and 6 members of the community, 3 suppliers of services, and 1 city councillor. The role of the Community Advisory Council is to help ensure that the Scarborough Hospital and Board of Directors are accountable and transparent to all the community. To do this, the Council will provide input to the Scarborough Hospital community engagement strategy and participate as appropriate. Will act as an educational resource for the Scarborough Hospital, the Board of Directors, and the community. Will participate in the review and development of TSH policies, program, and service consistent with the needs of the community, and on behalf of the community will challenge the Scarborough Hospital and staff to continually strive for excellence in the delivery of health care. Will support the Scarborough Hospital as it strives to become the center of excellence in health care for the global community, and promote Scarborough and advocate for the unique and diverse health needs of the community. CAC is independent from the TSH administration and reports directly to the TSH board, and we do this at every meeting. It is that speech given and report tabled by our chair on March the 5th that I would like to share with you today, because March the 5th was the critical day where the board met and just prior to them making the decision that we are talking about today, this is the speech that was delivered. We realize that we have to deal with realities when deciding on the future of the 2 campuses of the Scarborough Hospital. The first reality is that our hospital will have less money in the upcoming years and is facing potential deficits. Yet the government won't allow hospital to have deficit. Furthermore, the major part of this problem will occur because the provincial government's decision to reduce funding to acute care hospital. It's not just the Scarborough Hospital that is facing the problem. Just last week, the Health Minister, Deb Matthews, said that it's okay to close hospital bed. The Ontario Health Coalition has pages of documentation about major cuts to funding and the resultant reduction to or end the program in hospital throughout the province. The second reality we face is that we must maintain 2 robust, sustainable Scarborough Hospital campuses. The greatest concern has always been about the future of Birchmount. We need a hospital north of the 401, which, in case you don't realize, it is a major psychological barrier which divides Scarborough. I'm talking of the 401 being a big barrier. It serves a major growing segment of Scarborough population, and it cannot be allowed to become another Branson. The second reason we need Birchmount is that the general cannot handle all of the patients dealt with in both hospitals. Let's look at the numbers going annually to the emergency. 48,000 to Birchmount, 64,000 to the general emergency. The general emergency cannot handle all these people. These figures also show that Birchmount is not a minor hospital compared to the general. Therefore, the Scarborough Hospital Community Advisory Council is making recommendations that will ensure that there are enough indispensable programs at the Birchmount to guarantee that it remains a robust, sustainable hospital. These recommendations were unanimously approved by the CAC member who attended our meeting on February 25, 2013. The first recommendation is on maternal, newborn, child care, and women's wellness at the Birchmount. As the Maternal Newborn Child Care Advisory Committee has recommended that there is 1 site for maternal newborn child care, we believe that this site must be at the Birchmount. It should include women's wellness. Combine this will create a center of excellence. There are many sound reasons for citing this program at Birchmount. We need maternal newborn coverage for the area north of Highway 401 and in the west of Scarborough. The General and Rouge are close to each other in Scarborough East. It makes no sense to have 2 major maternal newborn sites close together in one area and none in the rest of our community. The presence of maternal newborn child care and women's wellness will strengthen Birchmount ER, which is critical for the surrounding community. And the Birchmount needs another center of excellence to ensure it remains a vital hospital. The General will be the site for other major surgeries such as complex, long-term surgery, and cancer care. Major residential developments along Shepherd, Finch, and Steeles are being built or planned. There are in Birchmount catchment area. In other words, this is the area of Scarborough that will grow the most in the future. The Birchmount campus is much easier to directly access today. The access to the general will even be more crowded in the future when all complex long-term surgeries occur at the general. The second recommendation was to enhance the ER plans at the Birchmount. The strategic plan refresh guarantees that there will be a 24/7 emergency at Birchmount. We recommend that step be taken to also guarantee that the Birchmount emergency will offer the same level of emergency service as it now does. Putting the maternal newborn child care at Birchmount will help to enhance the emergency. The Birchmount site must also have the nurses, doctors, and equipment to be a full-service emergency. If necessary, non-complex emergency surgery for gallbladder, appendicitis, etc. should be able to be done on an emergency basis at this site. In summary, we must be clear about what a 24/7 emergency at Birchmount means. Now, the operating room at the General, the third recommendation. Our third recommendation is that operating time at General be awarded equitably between surgeons from both campuses. We are recommending this because surgeons from the Birchmount who perform the more complex long-term surgery that would be transferred from Birchmount under the strategic plan refresh fear that surgeons who are currently at the General will get preference. They all must be treated equally and all must be considered from one hospital, the Scarborough Hospital. The fourth point is the transfer of patients to the General. The strategic plan refresh would require that some patients be transferred from the Birchmount to the General if it turns out that they require complex long-term surgery. Shuttle of patients and staff between the two sites must be carefully studied and planned to ensure optimum efficiencies and safety. We also hope that the implementation will be done with project management discipline so that nothing falls in the crack. This is why we are outlining the 5 elements of a discipline management system, which are approved detailed planning, deployment of proper resources, smooth execution on plan, on spec, and on budget, and accountability to deliver, then feedback mechanism in terms of stewardship of result versus plan. We have listened to the concern expressed about the strategic plan refresh, and our recommendations are designed to deal with these concerns. Change is being forced upon us. We must ensure that we do the best to ensure that all members of our community get the best possible care under these new circumstances. And it is signed by the president or the chair of our CAC committee.
Hello, my name is Seline Naji, and I'm just here to give a simple sort of mother's perspective as to my experience with the Scarborough General Hospital. Just to give you a little bit of background, I have 3 children. My oldest, Natasha, is 20 and in university, and then I started all over again. And I have a middle son who's 7, Caden, and I actually just gave birth to my 3rd son 25 days ago. Both my boys were born at the Scarborough General Hospital. My experiences are specifically related to my middle son, Caden. He was born on June 17th, 2006, at 37 weeks. And when he was initially born, everything was fine. We thought everything was perfect. He seemed like a normal, healthy, happy little boy. And then when he was 2.5 months old, he was extremely yellow and jaundice. So my husband and I took him into the emergency room at Scarborough General. And this is where we met Dr. Azzopardi. Caden had an extremely high bilirubin count. We stayed at Scarborough General for about 4 days doing various evaluations and testing. And it was determined that Caden had an extremely high liver enzyme count. There was no sort of specific name or diagnosis made for his condition. We were then referred over to Sick Kids Hospital by Dr. Azzopardi, where we spent about a month. In the month that we were at Sick Kids, they eliminated about 60 different conditions, and there was still no a diagnosis made for Caden. We still continue to go to Sick Kids on a yearly basis. When we first started going to Sick Kids, we were going to 7 different clinics. We're down to just one clinic, which is the GI clinic. And I just wanted to point out that Dr. Azzopardi was instrumental in getting us into Sick Kids in facilitating the process. He actually helped, he went above and beyond. He was calling me at like 2, 3 o'clock in the morning because we were trying to transition from Scarborough General into Sick Kids. Caden went through, like I said, every test imaginable, and still there was no diagnosis made. To have a sick child is completely unbearable. And then if you're taking away sort of the emergency room or the pediatric division of a hospital where we initially go for support and help, it's going to be a detriment to the community as a whole. I just want to also go back a few steps and let you know that before we lived in Scarborough, we lived in Etobicoke, very close to the Queensway Hospital. And that site eventually turned into a walk-in clinic, and there was no sort of emergency room facility after 10 o'clock. This made it extremely difficult because the next nearest hospital was in Mississauga, which was basically, you know, a town over, and there was no access to transportation to get there as well. When Caden was first born, my husband and I, we all lived in Scarborough. We now live in Markham, and even though you know, it's a bit of a travel for us to go from Markham into Scarborough, we still continue to go to the Scarborough General Hospital. We still continue to see Dr. Azzopardi, and I actually also have Dr. Wilcox as my obstetrician as well. So, I mean, I just wanted to kind of share with you my perspective in terms of my experience with the Scarborough General Hospital, how instrumental they were in getting us the support and the resources that we needed to make that initial sort of, well, I can't say diagnosis because there's no diagnosis been made for Caden's condition. He is thriving though and doing really, really well, and has been off medication for the last couple of years. So, I mean, I just wanted to take a few minutes to kind of point out my personal experience, and that's pretty much it.
Thank you very much for coming out.
You're welcome.
I'm the Director of Programs and Mission at Rosalie Hall. Rosalie Hall, for some of you who may not be familiar with it, is the building immediately adjacent to the hospital. And it's a bit of a history lesson for you as well. Come closer. Pardon? To the General Division of Scarborough. So Rosalie Hall is an accredited children's mental health agency, and we focus on providing services to young pregnant and parenting youth and their families. We're a Catholic heritage organization, and we have a 100-year history of providing services in Toronto, and certainly in Scarborough as well. Rosalie Hall was founded by the Sisters of Misericordia, and the Reeve of Scarborough, Oliver Crockford at that time, asked the sisters to move to Scarborough. Their initial services were down on Bond Street, to build Scarborough Hospital. So the sisters embraced this mission. They fundraised, I guess that version of fundraising back in the 50s, purchased the land and the land right next to Scarborough General to provide Rosalie Hall. The sisters agreed to the mission in order to be able to access medical services for their clients. In the 50s, it was very difficult to access services for pregnant and parenting women who were single, and also to provide services for those children. So they purchased the land, they conceived, they planned, they financed and oversaw the construction of the hospital, and in fact were involved with the hospital until 1972 when they turned over ownership to the province of Ontario. They were also instrumental in developing the supporting structures around the hospital. So they founded the medical buildings, provided the structure, because they felt that really residents of Scarborough as a growing area would need access to those services of established medical practices. Today, Rosalie Hall continues in its mission of providing services from a holistic perspective. So we have a continuum of services from youth outreach, in the community, education, child development, employment counseling, and residential services. The board of directors and the agency staff are appealing to the expert panel established today to support a model of service that allows equitable access to maternal newborn services for all residents of East Toronto. In 2012-2013, Rosalie Hall served 250 women and 169 babies. Specific population represents some of the most vulnerable clients in our society. Research has shown us that 84% of our young women come with a history of physical, emotional, or sexual abuse, and that study was done through Sick Kids just in 2012. Most come with a history of unresolved trauma. They've had involvement with child welfare. Often they're wards of the child welfare societies, or they have been in care off and on throughout their lives. Research has also found that they really need involvement with a stable, comprehensive continuum of services for 3 to 4 years in order to be able to change the trajectory of their lives. Many of them come from the geographic area in central Scarborough. As you're aware, the United Way identified 13 priority neighborhoods in 2003. And those were priority neighborhoods that were at risk because of the level of poverty, violence, demographics, socioeconomic conditions. 6 of those neighborhoods are in Scarborough. So truly we are seeing the most vulnerable of youth. The profile of issues meant that more women and children were at risk, and also 1 in 3 families in this area were lone parent families. It's impacted the overall health and vitality of the residents, and the investments were really required to promote sustainability in those neighborhoods. So many of the young families in Scarborough have really taken upon the concept of Scarborough General being their hospital. These are clients who typically don't have access to vehicles to get there. They come by way of public transit. The ease of access by public transit, the availability of supportive services that address the holistic needs, and the access to specialties that help care for both mom and babe are an essential investment in these children's lives. Rosalie Hall is committed to caring for these families and asks you to support the ongoing engagement of Scarborough Hospital General's Division, a maternal newborn program in our partnership that spanned over half a century. When we look specifically at Rosalie Hall, with our partnership with Scarborough Hospital, it's essential we have birthing services accessible close by from a program stability and structure perspective. When I just went through the residential program and did a review over the last 2 months, looking at the number of visits to the emergency unit, to the obstetrical triage unit, to labor and delivery, to follow-up clinics, we're looking at average of 15 visits per week for these young families to the hospital. They visited a variety of clinics, the breastfeeding clinic, the postpartum clinic, the prenatal class, and really our partnership is paramount in delivering our services. Our residential program is the most intensive of all our services, and in the time that we have clients there, we really have a responsibility to assess their parenting capacity. Many of our babies end up in the special care nursery at Scarborough General. There's a couple in there right now. And having the ease for clients to be there while accessing care and treatment within our resources back and forth really allows us to work with child welfare in a close way to determine parenting capacity and the ability and viability to have a parenting plan. Birthing is really a 56-year tradition at Scarborough Hospital. I was born there. My husband was born there. I worked there for a number of years, and now I'm next door. Certainly services have changed over time, but the same mission that drew the sisters is still a relevant mission today. Scarborough Hospital does 2,800 deliveries or in that area, and yet they've been able to continue to demonstrate excellence in practice. They've introduced innovative programs, and they've had culturally sensitive programs over the year. They introduced the first breastfeeding clinic, the first postpartum clinic, and the implementation of specialized care and treatment for newborns requiring additional support. Many other programs have been developed as emerging needs have developed. By removing birthing services and the loss of associated services, vulnerable young parents will be placed at risk in Scarborough. By removing services from the center of Scarborough, young families without resources will be forced to take tortuous routes by TTC to access care that they and their children need and are entitled to. If we as a society believe in the right of health and well-being of all individuals, we need you as an expert panel to believe in the right of these youth in Scarborough to access service without undue hardship. The sisters had the faith to commit to services in Scarborough and endured many hardships and difficult and trying circumstances while paying the costs associated with building and running the hospital. We ask that you consider the inherent responsibility to ensure that the mission continues by maintaining birthing services at Scarborough General Hospital Division.
Do you have a sense of what percent of your clients come from the general site versus come elsewhere in Scarborough, or specifically the Birchmount site?
Well, they're not referred to us through the hospital. Really our clients that come to the residential program have run out of all other resources. They don't have family supports. Some of them come from shelters to us and really need some stability. We don't believe that young women who are pregnant belong in shelters. Probably the numbers that deliver with you of our residential clients, or deliver at Scarborough General of our residential clients, we probably have about 70%. Because of the nature of our population, many of them end up in a level 3 center downtown.
If the objectives are going to come, you will move.
Mm-hmm.
In your future. Have you worked out a plan for this?
Well, no, unfortunately, I've been part of the maternal newborn group with the hospital over the years, and we've had some discussion, but I wasn't involved in these recent pieces until we saw it actually in the media earlier this week. So we're actually struggling right now considerably. It will have a major impact on our services. It means basically any client who's in the residence who's experiencing decreased fetal movement, bleeding, fever, abnormality during her pregnancy, or a baby who's ill in program is then going to have to be sent via taxi, whereas right now we are able to make the transition across the parking lot relatively easy with staff. This is a huge impact for us because we are only staffed with 2 staff at night, and I can't see the safety or advisability of sending a client off alone during the night without a staff member. Many of our clients we've had clients as young as 12. Our clients range in age in the residential program from 12 to 21, and they need those ongoing supports. So it will have significant impacts for us, both from an economic perspective, a staffing perspective, and really we have a huge concern around the continuity of care piece.
Good afternoon, and thank you for contributing all of your valuable time to help us to ensure high-quality health care for the families of Scarborough. My name is Peter Azzopardi, and I have been a member of the medical staff for over 23 years at the Scarborough Hospital. I've been the Chief of Pediatrics for 18 years and active in program management as a medical director for most of those years. Next slide. Is this, which one? There? Okay, great. Thanks. I must say that we have made a significant progress in integrating the 2 sites of our hospital since our merger many years ago. Our pediatric department was the first to hold joint educational rounds and business meetings. All of our policies, procedures, and paperwork are identical at each site, and we share educators, staff, and other support staff. Medical and nursing personnel routinely cross sites to help out when staffing issues arise. We had a joint chief of obstetrics who actually moved her obstetrics practice to the Birchmount site to help bolster the birthing numbers. We deliver high-quality care with leading-edge participation in programs such as More OB. We participate in multidisciplinary case reviews and innovative programs to meet the needs of those who depend on us. We are leaders in the lowest newborn mortality rates among community hospitals in Ontario. We have high-acuity pediatric ER care and very low C-section rates. At the general site, in-house pediatric, obstetric, and anesthesia staff are present around the clock every day of the year. Our hospital is facing serious financial challenges, and the search for savings once again raised the possibility of consolidations of services to one site. Unfortunately, we are an easy target. Pediatric and maternity care are not protected by wait time funding or by special provincial funds such as cancer care or dialysis. Our bed occupancy is variable, and our length of stays have been moving downward in both obstetric and pediatric care. Despite the fact that the general site leads the Central East Lynn in the number of deliveries per year, there are days when few mums arrive in labor and other days when we are overflowing and have to transfer patients to other hospitals. All 3 of our programs need the capacity to handle the peaks and valleys of our patient flow, to maximize access, and to minimize transfer to other hospitals. And by 3 parts of the program, I mean the obstetric side, the pediatric floor, and the NICU. 1 year ago, the hospital hired the Corpus Sanchez group to examine our program. Rather than identifying meaningful ways to remain leaders in our service delivery and attract new maternity clients, the report focused on consolidation and erroneously identified cost savings that were completely unrealistic. There are a multitude of other errors in the report, but I have very limited time, and I would like to focus on the financial calculations, if you don't mind. I'm sure you've heard a lot from others about the services that we provide, and I don't want to repeat all of those things here. The usual route to decide on the number of beds per unit is to look at the number of hours per patient day or the typical average occupancy of a unit. When you do this with units that have fluctuating census, you find an average that is often lower than the needs of your community. And this is a typical graph that shows a daily census in our NICU at one of the sites of our hospital. And you can see that at some times we're as low as a 30% occupancy rate, and other times we're as high as 120% in our occupancy rate. And we have to flex up and down because in our business we can't tell which mothers to come in and deliver at which time. We can't tell how many children are going to come in the emergency department sick at one time. And we need the flexibility to move these patients out of emerge and into appropriate care areas. So when we look at the percentage of times that we need certain numbers of beds, we come up with this type of a chart. And this is what I use to tell our program what we need in terms of our numbers of beds. We currently have a total of 20 beds in our unit. The Corpus Sanchez group decided that we would only need 15 beds in a combined unit and deliver the same number of babies. This is for the NICU. 15 beds by this graph basically means that we would be closed to service 50% of the time. You can see that it says 53% there. That means we'd be reaching our bed occupancy every other day and having to close and not offer service to that community. In fact, to properly offer care to the community and accept a 5% closure rate, in fact, we would still need the 20 beds that we have today. We performed this exercise with the other programs within our units and came up with similar concerns about underestimation of the number of beds required in a consolidated unit. The identified savings by the Corpus Sanchez group was approximately 4.4 million. In communications between the hospital, the board, and the public, that number has ranged anywhere from 4 million to 8 million. And I'm not sure where some of these other numbers are coming from. This data has been presented to the management team of the hospital, and yet the old numbers continue to be manifested through all of our public reports. In fact, the cost savings based on a bed occupancy by census route is in the range of 1.3 million. When you look at staffing this unit and you go into FTEs, the comparison between the FTEs under the average census versus the daily census route is also way off, and our identified cost savings in a consolidated unit are barely over $1 million. This is considerably less than the amount of money that has been identified in reports, and it really brings into question the reasons why we're going after a consolidated unit when it has such an impact on safety in our community. As well, this data was used by the Hay report without any further checks and balances and put directly into their report as work already being completed. And so the Hay data just perpetuates the myth of additional savings. Unfortunately, there was no details in either report about what a new center of excellence would look like for women and children or what programs they would offer that were new. The issues regarding access and transport you've heard a lot about today, and I don't need to go over that. The renovation costs that were identified for the entire plan of the strategic plan refresh was 1.8 million. This would be an inadequate amount to renovate the NICU, the pediatric floor, the birthing center, and the operating rooms to deal with the changes that were proposed. Just 10 years ago, we built a new obstetrics and delivery suite at the general site, and we spent $8 million to do that. There's no details regarding supporting a pediatric present at the closed site. In fact, this recommendation was added to the model of care within 24 hours of the board voting on it, and this recommendation was never discussed at any of the other meetings within our groups. It should be noted that when we did have conversations about siting and when we were asked to choose site, the Performance Improvement Committee of this hospital did declare that the general site would be the preferred site. There was an overwhelming vote of the physicians on that panel, including doctors from both sides of the hospital, that chose the general site over the gray site because of the services that are present in the general site. Again, I'm presuming you've heard about that again? All right, I need to speed up. The main problem with our plan was that it was a one-year plan. Consolidated savings go towards our deficit and don't improve patient care, and there are no new programs for our high-needs community. It should be noted that apart from the patient, that emergency care in Scarborough is unsafe without pediatrics and will lead to poor outcomes. This is a community at risk. Scarborough is surely the most underserviced area of our city in terms of programs for women and children. The highest numbers of children with chronic complex care needs in Ontario reside in our LHIN. There's no home-based therapy for disabled children. Families waste many months on waiting lists and get exacerbated because of delays in developmental assessments and speech therapy. There's declining and extremely limited support for even the basics of healthcare, such as breastfeeding. Postpartum depression is rampant, and we have virtually no mental health services for children and adolescents, despite rising levels of autism, anxiety, and depression. There is no hospital in Ontario that has pediatric coverage of an emergency room without a robust obstetrics and pediatric program on that site. That model does not exist, and that was the model that we were asked to put together to maintain services at the general site. Finding a sustainable way to provide that kind of coverage would be impossible. A shortage of pediatricians who are willing to take on hospital work is present throughout our LHIN and throughout Ontario. Only the general site in Centenary are not looking for pediatricians at this moment. Every other hospital is looking for a pediatrician. Financial incentives to keep pediatricians on call drain resources from hospitals. And even if we could work out some sort of rotating schedule, the lack of support from other vital team members in the emergency department would mean a rapid decline in the quality of care provided. Would the board mind if I continue my presentation?
We have to be fair to everyone who's here. If you can finish it in 30 seconds.
All right, I'll move on.
Thank you for your presentation.
No, I just would like to just finish if you don't mind. Yeah. Okay. I am the chief of the department being asked to consolidate. I'm also the medical director. Would it be possible to take one more minute of your time? I just would rather finish up if you don't mind. Children are among the most challenging of patients in an emergency room. Everything from assessing vital signs to taking x-rays and blood work is more time-consuming and fraught with opportunities for errors. The journal Pediatrics points out that children who are not able to discuss their symptoms with a physician directly and parents who are not fluent in English represent the highest risk for medical errors among ER patients. Do I have a vision for the future? Absolutely. I am hopeful that the newly established Central East LHIN Maternal, Newborn and Youth Advisory Board, along with the LHIN directions regarding our Rouge Valley partner, will finally help solve some of the serious gaps in service in this neighborhood. We do not need to build another hospital for sick children in Toronto, nor do we need another Level 3 perinatal center. There is no need to cohort every pediatric or NICU bed at fewer centers, since we have shown that high quality and cost-effective care can exist in each of our hospitals. Our model of a dedicated hospital pediatric care area with inpatients, day surgery, and ER-focused clinics facilitates critical mass and ensures that pediatric trained nurses are available for the child who suddenly becomes unwell or has complex care needs. Our emergency physicians are demanding the support of pediatricians at the bedside. The emergency departments are clearly the safety net for this community. The resolution to move the newborn and maternal program from the general site will lead to substandard and unsafe care for infants and children who will continue to seek help at their closest hospital. Thank you very much. No, PedLink or PedLink is separate. They're outpatients. They're not necessarily admitted. Some of the patients from the PedLink program are not able to go home, so they are eventually admitted, but then they're counted as admitted patients.
Okay, and then further question, as a leader, we oftentimes need to consider multiple sides and multiple solutions. Are there potential benefits that you would see or the group would see to consolidation? And further to that, what are some of the alternate models that you've considered in provision of care?
You know, I know our colleagues, particularly in obstetrics, are worried about, optimum numbers of deliveries per site. And there aren't a lot of details around that in terms of quality of care and critical mass, actually. This has been examined through the Child Health Network for years. There are over 30 hospitals in Ontario that deliver less than 2,000 deliveries a year. So all of the hospitals in Scarborough are above that mark. The people that have reviewed the program haven't found problems with that. There are definite advantages to consolidation. I wouldn't have to be on call as often. I mean, that would be one major thing. Most of us, however, that do call in the hospital actually like doing what we do, and we know that we're providing a valuable service. That's why we're willing to stay in the hospital on nights and weekends. There are certain programs that we are missing in Scarborough, but a lot of those aren't going to be helped by a consolidated unit. We already have some budgetary funds for outpatient therapy. Most of the things we need to do is to continue to liaise and work together with our partners in the community. I see integration not as necessarily as a consolidation, but I see integration as a way to move all three partners in Scarborough together in one common vision for the families of Scarborough. It doesn't mean that everything has to be in one box. The care we need for this particular part of the city has to be accessible. We can have different things in each box, an outpatient facility that is high quality in one area, an inpatient facility elsewhere. But what we need to do is make sure that the basics of the care behind the front door is there for the families that arrive. So the biggest problem with this is not necessarily what the consolidated unit looks like. That's an easy thing. Sure, I'd like to be in a hospital with 4,000, 5,000 deliveries. There's lots of things that would potentially enable, and particularly more time off. But it's what we leave behind in Scarborough that we've always had a problem with. And it was a common message from both sites of our hospital. Both pediatric departments of our hospital said the same thing. Leaving behind an emergency room without pediatric covers in this area of the city is dangerous.
Any other questions, comments?
Just to paraphrase something that you mentioned, I think you said consolidation would impact on patient safety.
Yeah.
Are you talking about consolidation of the Birchmount site?
No, consolidation at any of the sites in Scarborough. It's not the safety that I'm worried about in the consolidated center. Hopefully there you'd be able to have a bit more critical mass, but it's even with a large program like the one at the general site, it's been difficult to retain people that are ancillary to the program, like lactation consultants or occupational therapists for pediatrics. Hopefully, right now those therapists run between two sites to try to deliver service. If we're all on one site, we'd have a lot less travel time. But apart from that, I don't see any major differences. We're not trying to build a center where we can do cardiac surgery for children. We're not trying to duplicate the services of sick kids. It would be nice maybe to have a pediatric general surgeon in this area of the town, but we're not really finding that as a major problem in terms of the care gaps that are out here. Most of the care gaps are really based in mental health and outpatient specialized services. So that's one thing of it. When I talk about the dangers of patient safety, it's what we leave behind in a unit that we can't cover. When you've got 20,000 kids coming to the emergency department at Scarborough General and you don't have a pediatrician on call, that's a problem. And no matter how many signs you put outside the place saying adults only and how many languages you do that, you're still going to see what I see on a regular basis, parents running in with a child in their arms. And I can't handle that patient if I'm at the Birchmount site, nor could I do it if we were at the general site and the Birchmount site. So yes, I would love to work in a single hospital with 5,000 deliveries and oodles of pediatric beds, but I know my mission in Scarborough is to make sure that the areas of Scarborough are safe, and that's where my concerns are.
Along those lines, there are other places in the province that have moved pediatrics in a similar fashion into one site, and they still have emergencies down the road. And you say that this is an unsafe and untenable situation. Have you and your group studied the other areas? Can you comment on?
Yeah, I think we have. In fact, I spent last Friday morning with the CEO at McMaster Children's Hospital actually going over how things have worked in Hamilton, for example, and I've also looked into the way things work at other large community centers. I think the biggest difference, of course, is that these are university centers, number one. Number two, they're trying to build critical mass to make a tertiary care center for children. And the University Hospital at McMaster, not the University Hospital, but the Children's Hospital at McMaster now has a children's-only emergency department. So the vast majority of children in Hamilton, according to your CEO, are going to that center. They're seeing very few children at other centers, and those children aren't being seen by a pediatrician. From what I understand, again, this is through the CEO, even at St. Joe's in Hamilton, where they do have a large birthing service, about 3,500 deliveries a year, there are general pediatricians on call to the case room, but they do not see children in the emergency department. And that model also exists in Ottawa. We have a pediatrician who recently moved to us from Ottawa. She worked at Montfort, and it's a French-speaking part of the city. But she said that she only is responsible to the birthing area, not to the emergency room. There's too few numbers of children to go there. When there's a transport needed, the emergency doctors talk directly to the folks at the children's hospital in the local city. So it's a bit of a different model.
So you're not familiar with the situation in Kitchener-Waterloo?
So I don't know exactly what's happening in Kitchener-Waterloo, and I'd be happy to look at that program.
You might want to talk to your colleagues then.
So, I mean, in terms of coverage, we would certainly be able to give phone coverage to a site that didn't have.
Well, we're not going to discuss the actual nuts
Sure.
and bolts of this, but I do suggest that there are other models that are more promising.
Well, I would like to hear more of the. I mean, Kitchener-Waterloo, I think, might be the only other one that I know of. I've looked pretty hard at large communities, and I've had no luck finding other programs that are like ours.
You seem very, very dedicated, and I really appreciate all the time you spent. And thank you very much.
Dear members of the panel, thank you for hearing me today. Thank you for listening to all the people in Scarborough. I'd like to present to you today my perspective as an emergency physician. My name is Dov Soberman. I'm into my 19th year of full-time emergency practice in Scarborough, and have worked extensively at all 3 Scarborough hospitals. My colleagues are here in solidarity with me, and if you put us all together, there's about 100 years of emergency room experience. You would even see more emergency room doctors here today, except that most are either working or at a previously scheduled department retreat, an educational event. I've worked at 6 ERs in the GTA. All are community hospitals. All provide obstetrics, pediatrics, and inpatient emergency surgery. The proposals to consolidate programs to one or the other site of the Scarborough Hospital place at risk mothers and children and those requiring surgery. Starting with pediatrics, here are some important facts derived from the Ministry of Health database. In 2011, the Scarborough ER saw approximately 100 pediatric patients daily. This is more than are seen at the tertiary pediatric hospital at McMaster and Hamilton. ER volumes in Scarborough continue to rise. The Birchmount campus alone sees more kids daily than the combined pediatric volumes of Toronto General, Toronto Western, Mount Sinai, and St. Mike's. The safety matrix that allows tertiary care centres, such as may be found in Hamilton and downtown Toronto, to serve their community's children hinges on the comprehensive and resource-rich medical and teaching environments in those communities. It also hinges on geography. In Hamilton, McMaster University Children's Hospital is about 6 kilometres from the community's other hospitals, one of which can attract pediatrics coverage with an extensive obstetrics program. The myth that pediatrics will cover an ER in a hospital without obstetrics, tertiary care centres such as Sick Kids accepted, is not supported in Hamilton, where pediatrics does not cover such ERs, and no pediatrician in Hamilton covers more than 1 ER at a time. In downtown Toronto, the Sick Kids ER offers every service under the sun. It's less than 100 metres from Toronto General and Mount Sinai, 1.8 kilometres from Toronto Western, 1.3 kilometres from St. Mike's. That's all from Google Maps. None of the other communities where I work would entertain the removal from their community hospital of a critical local service such as pediatrics, simply because it's unsafe. I know this because I've been the duty physician at no less than 10 pediatric VSA code pinks in the ERs of Scarborough, and have delivered about 10 babies in the ERs of Scarborough as well. To pretend that it can be safely done alone and without the support of pediatrics and obstetrics is misguided. How much in marginal savings can justify the loss of a child's life? Further, as was acknowledged in the Fluellen case, geography is important. In that case, an 18-year-old asthmatic died after a delay in care while being transported to a hospital further away than the nearest local ER. This did not happen in Bobcaygeon, or Hagersville, or Fergus, but right on our doorstep here in Scarborough, and the resulting lawsuit is a testament to how this failure was viewed publicly and in the courts. My ER colleagues all have horror stories like mine, where children have died or come close to death. Why do we entertain offering ER care that will fall below the standard of a GTA community ER? We are not endowed with the resources of downtown Toronto or a teaching hospital like Hamilton, and have none of the tertiary care buffers nor the benefits of geography to provide consolidated ER care for the community's women and children. It would be shameful, unsafe, and unprecedented to have the busiest ER between Vic Park and Oshawa run with no in-house obstetric pediatric program to back it up, as was recently proposed to the LIM. I will comment briefly now on the proposal to consolidate inpatient surgery to one campus and to remove it from the Birchmount. The details of safety or lack thereof may be described by the general surgeons. To pretend that an institution functions as an ER in the GTA but must transfer out after-hours surgical cases is mistaken. Monday to Friday, 9 to 5 represents about 23% of the hours in a week. That would leave 77% of the week's hours with no acute surgery to support ER, and you could add holiday closures on top of that too. It is a recipe to close the Birchmount as a hospital and convert it to a walk-in clinic a la Branson. This rings particularly true as a consolidation proposed by Hayes 2B was projected in the first year to leave only some 5 to 6 acute surgical beds at the Birchmount as proposed to the surgical department at TSH. How many of those beds could be expected to survive with the next round of cuts, which would double the cuts of the first year? Just because it is not explicitly closing the ER in the first year of cuts does not change the fact that closure of ER would be inevitable. Scarborough has none of the dynamic programs that are seen in Kitchener-Waterloo, where a cancer center, cardiac surgery, including bypass and valve surgery, and thoracic surgery are there to bolster the community's surgical programs and keep the two hospitals' ERs, separated by 2.8 kilometers, dynamic. Thank you for your time here. It puzzles me that the opinions of over 300 of the medical staff at TSH, who best know the needs of Scarborough's communities and who signed a petition which rejected 2B as unsafe, are insufficient to dissuade dangerous program shuffling. Please consider carefully any so-called safety matrix for the women, children, and surgical patients of Scarborough. Pediatrics, women's care, and after-hours surgery are like your car's airbags or your community's police and fire departments. You may not have used them today, but you certainly can't toss them aside in the name of specious savings. Cutting down acute care, maternal, pediatric, surgical, and ER services in Scarborough is unwise and unsafe. Thank you for your time.
Thank you for your presentation.
Yeah, just one question. With the pediatric patients that you actually see in this department, what percentage of them do you see that actually discharge them home without any involvement with the pediatrician?
I don't have those numbers. I don't know. But yeah, I couldn't tell you. I can tell you that I've run 2 simultaneous code pinks on drownings and fire victims. 2 episodes where 2 dead kids were brought in together. That's not something that you do alone. The horror stories, I mean, there are other doctors here that can tell you.
Likewise, if they did move the pediatric service up to the Birchmount campus, you still have an emergency department that's open up at the Scarborough campus. What is the emergency department's sort of, how are you going to deal with the pediatric population that's still walking through your door?
You know, as you know, you're an emergency physician. You deal with what comes through the door. I used to work not far from Hamilton in Hagersville, and I remember a patient came in and we needed to ventilate the patient all night. I ventilated, the nurse ventilated, the patient's wife ventilated, the security guard ventilated, everyone vented the patient. That doesn't make it the right thing to do when you have a certain number of resources. Hagersville is different than Scarborough. And so there's an expectation of care. So can you do anything? Sure you can. Can you close North York General Hospital? Of course you can.